The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and thank you for your participation in today's webinar, Introduction to Trauma-Informed Care for the Children, Caregivers, and Ourselves. A few notes before we get started. My name is Carrie Norton. I'm the Early Childhood Comprehensive Systems Project Coordinator and available for questions today. When using GoToMeeting or GoToWebinar, it's best viewed in all screen mode, so you may want to minimize your control panel unless typing in a question. However, please note that during the webinar, you will be in listen-only mode, and you will only be able to type questions into the chat box. If there is time at the end of today's webinar, we will do our best to answer questions. However, if we do not have time, you're welcome to type in your question along with your email, and Sherry will do her best to respond to questions by the end of today. Certificates will be provided for all those that participate for the duration of the training, and certificates list org and registry credit information, as well as infant mental health endorsement core competencies. These will be sent to you via email by the email address that you provided at registration. If you're watching this webinar in a room with other colleagues, you may email me the names of those who participated who wish to receive a certificate at the completion of this webinar. With that, I will turn the control over to Dr. Sherry Alderman, who's presenting this webinar. Thank you.
Good morning, everyone. This is Sherry. Thank you all for joining this webinar this morning. I'm very excited to share this information with you. I'd like to give a special welcome to everyone across the state of Oregon, as well as those calling in and joining us from our neighboring state, Washington. Also a special welcome to those of you in Michigan who are joining this webinar. And a warm hello to my fellow colleagues in New Mexico who are signing on. If I have missed any states, please enter your state into the chat box, and I would be more than happy to say hello to you as well. We'll begin the slides now. The agenda, we will have a reflection activity at the beginning. We're going to touch on child rearing and cultural considerations from a very broad perspective. We'll talk about community as a caregiver and the importance of resilience in trauma. And then we will look at how to better understand behavior from a trauma-informed perspective. And finally, a very introductory level discussion on organizational trauma-informed approach. The goals today are that at the conclusion of this presentation, you will be able to describe the human history and shift in the social environment from a rich array of varied and nearly continuous human interactions to relative isolation, and to increase your awareness of the influence of past trauma on current behavior seen in children, caregivers, and ourselves. The infant mental health endorsement core competencies, for those of you working on your infant mental health endorsement, covered today will be direct service skills and reflection. So first, a reflection activity. Ask yourself and jot down what are some of your triggers that make you upset or frustrated in your work or in your life in general. And think about, too, where do you think they come from and how do you deal with them? So just take just a moment here to jot down your triggers and where they come from and how you deal with them. This is something that you'll be reflecting on, hopefully, throughout the presentation, and we will be revisiting at the end of the presentation. I'll give you a moment to do that. So as you're jotting down your triggers, you can think about, we all have them, and the work that we do sometimes actually triggers those as well. All right, so we'll continue on, and again, we'll be revisiting that at the end of the presentation. It's something you can reflect on throughout the presentation as well. So first, let's look at child rearing and cultural considerations. Okay. First, I would like to recognize Barbara Rogoff and her book, The Cultural Nature of Human Development, from which I have heavily borrowed. I am very much indebted to her. I have no financial disclosures, but I certainly am very much indebted to Dr. Rogoff for her work in informing the first part of this presentation. Secure attachment, we talk a lot about that. I still like to use Bowlby's and Ainsworth's definition for secure attachment. It involves a system of behavioral patterns that brings a young child and an attachment figure or the caregiver together, and that caregiver is emotionally available and responsive so that that child, while feeling insecure or unsafe, re-establishes a sense of safety and able to be fully engaged in the world. Oftentimes we think of that as dyadic, that is involving the child and a caregiver. Sometimes we think of it as triadic when we're talking about the child, the father, and the mother. But secure attachment, as we typically think of it, comes from research that has primarily come out of the United States and Western Europe. And it is a reflection, therefore, of the cultural values and practices that predominate in the United States and Western Europe. For instance, the value that we typically place on autonomy and independence, that's an Anglo culture. We expect children to sleep independently. We expect children to tolerate being dropped off for a lengthy period of time with a caregiver outside of the home. And we even characterize the development of a child as development of autonomy. In contrast, or certainly different way of thinking about early childhood development is when we look at the Puerto Rican culture, there is more of a value placed on relatedness rather than autonomy and independence, and a value on teaching a child proper demeanor and how to be courteous and respectfully attentive rather than expressing independent thoughts and ideas. So that's a difference that we have when we're looking at early childhood development that is culturally based and not universally a value placed throughout the world. And infants become attached to not just the person or the two caregivers, not just dyadic or triadic, but also they become attached to the specific conditions that are drawn through those relationships that give them the comfort that they need and resolve the anxiety that they're feeling when they are uncomfortable and need to be in that safe condition with a provider. And also, when we're talking about parenting, mothers and fathers' care of their child does involve assuring that they have connections with others and that others are involved in their child's life and keep them safe and nurtured. So mothers and fathers' relationship with their child is linked with the parents' relationship with the community around them. And that community, well, that community is all of us, all of the professionals that work with families with young children. So when we think about shared responsibility in child rearing, it's important to also remember once in a while that for more than 90% of human history, we actually, as a species, have lived in small hunter-gatherer clans and inherently had very little, if any, privacy. And those children and ourselves had almost a continuous exposure to social interactions, and with a multitude of, with a variety, I should say, of people, so that a child from the very beginning experiences a wide variety of social emotional interactions with a variety of people. And this is how the brain has evolved and is really dependent on for robust development. Those tribes on average had 40 members in them, and it was a wide range of ages as well, the elders, the siblings, the parents, the extended family. And on average, children under 6 years of age actually really did have 3 or more caregiving adults to support them, primarily in their development. Here's a graph showing how the number of household members has dropped significantly from those times when we lived in tribes all the way to the current. You see a precipitous drop there over many years, so that now children are exposed to far fewer relationships within the household. In fact, the 2000 census showed that only 4% of U.S. households had 3 generations in the home, and a quarter of households had only 1 person in the home. And on the average, U.S. babies have a little bit less than 2 companions in their intimate relationships. And when we think about that and reflect back on the value that the dominant culture in the U.S. has placed on autonomy and independence, I begin to question whether or not that is a value of choice or perhaps a value of necessity, that it is important that we develop autonomy and independence at an early age because of the lack of social interactions and primary interactions that we have in our lives. Now, in contrast, when we look at other parts of the world, for instance, in rural communities in Kenya, infants have on average over 6 companions closely involved in the rearing of children. And a little bit closer to home, the Native American, Native Hawaiian culture, preschoolers there have on average 17 active caregivers. So again, getting back to that very robust and rich environment of social interaction. And it's important to know as well that that shared responsibility of caring for infants among a large number of active caregivers does not seem to get in the way of the close attachment that is so special between that child and the mother and father. So we have now the concept of community as caregiver. So let's delve into that now. So in many parts of the world, currently and historically, the daily supervision of children is the responsibility of the whole community. And those of you who have traveled internationally have probably seen that firsthand, that it's not just the parent who is involved in watching out for the child and even disciplining the child, but it is any adult around that child who does have that duty. And children are considered in many cultures to actually belong to the community and as well as the family. And everyone in that community is expected to comfort the child when the child needs comforting, to instruct and teach the child, and to discipline them. In contrast, industrialized nations have developed a different kind of caregiving community consisting of child-rearing experts, home visiting, very important component, pediatricians, even advice books, specialists who are paid to take care of young children, and teachers. So there's where we are as professionals working with young children and families. We are the caregiving community for our young children. So when we think about ourselves as an important component of that caregiving community, it's important for us to begin to think about self-care and the importance of resilience and the importance of recognizing trauma. So let's talk a little bit about resilience and trauma. Resilience is the capacity to respond to adversity and thrive. So there is adversity in our lives, and it's a natural part of life, and it's important that we have the resilience to be able to rebound from that adversity and continue to thrive, and that's what resilience is. Resiliency in some areas is considered to consist of 4 components: stable, caring, and supportive relationships. Those relationships are very important not only in childhood but throughout life, and that is where we get a lot of our resilience. It's important to also have a sense of control and mastery over our own life circumstances, to be hopeful that and feel capable of being able to rebound from adversity, and to have strong self-regulation skills. And we'll be talking a little bit more about how we develop that as a child and how important that is in our lives, and how that contributes to resiliency is also very important. And to be anchored in our own faith and cultural traditions, to be able to have a foundation for rebounding from adversity and thrive. Felidi's work looking at adverse childhood experiences as reported by adults recalling their childhood, actually looking at a large group of adults who were at the time originally in the obesity clinic and were not responding to typical medical care. Surveyed them. So these were people who were insured by Kaiser, so they were by and large pretty healthy population and probably a working population, and found that, much to everyone's surprise, that they reported at least one adverse childhood experience, and these were significant. These were abuse, these were domestic violence, these were an incarcerated parent, mental health conditions in the home, etc. They reported those at a pretty high frequency. And so that was our first introduction to the prevalence of adverse childhood experiences, and we have continued to build on that knowledge over the last several decades since that study was published. In fact, what Felidi found that there were only 1/3 of that specific Kaiser population had a score of 0, had no adverse childhood experiences listed on the previous slide. And so a majority of them did have at least 1. And in fact, for those who had 1, they were very likely to have 2. So very few, only a small segment had 0, very few had 1, and most had 2 or more. 17% had 4 or more of those events in childhood, and 11% had 5 or more. This is also very much a women's issue. More women than men fell into the category of having 5 or more adverse childhood experiences on this survey. And what this means is that we see that as the number of adverse childhood experiences grows, we see an increased risk for cardiovascular disease, lung disease, mental health issues, and substance abuse. The illustration on the right, kind of sometimes referred to as the oil spill diagram, shows that for each of those medical conditions, significant fraction of that can be attributed to adverse childhood experiences. Another study, Finkelhor's work, actually was a phone survey to families who had young children in the home. So this, well, as Felides was asking adults to recall adverse childhood experiences, Finkelhor's work was actually asking if the household with a young child present had experienced a violent experience. And through that, showed that 60% had experienced some kind of violence in the last year, and almost 11% had experienced 5 or more. He expanded those adverse experiences to community crime exposure as well. So adverse experiences are highly prevalent in American culture and among population. So what does this mean for brain development? This means that with a foundation of adverse childhood experiences, we have a disruption in the neurodevelopment, that the way the brain actually develops, the brain architecture, and that goes on to influence a person's social emotional development and cognitive development. And from there, with social emotional and cognitive impairment, that goes on to health risk behaviors and early morbidity and social problems, and eventually death. So what we have is that we have a progression from the time of conception all the way to early death due to adverse childhood experiences as the foundation. So stress is a natural component of life, and our bodies are very well adapted to acute stress. It's important for survival to be able to respond quickly. Our heart rate goes up, our blood is shunted to our muscles to be able to fight or flee a dangerous situation, and we have an intermittent increase in stress hormone, cortisol for instance, in response. When it's a positive stress, however, it does return back to the normal unstressed state. So that's a very common event. And the importance is that you do return back to the state. There is also tolerable stress, and tolerable stress are the stresses that occur within a supportive relationship. That supportive relationship buffers the person, or in the case of this illustration, the child, so that with support in that relationship, they can tolerate that increase in stress hormones and all of the feelings in the body that accompany that, and return back to a healthy, non-stress state. Toxic stress is in the absence of protective relationships, and this is toxic stress occurs without that relationship to bring a child back to a supportive, healthy, regulated state and non-stressed, and so that stress goes on and longer than is healthful for the body and becomes toxic to brain development. And as a result, toxic stress or prolonged stress outside of a protective relationship results in altered brain architecture, in poor self-regulation, and we'll go into more detail on that, in actually cognitive impairments, learning impairments, and we'll touch on that a bit in a minute here, poor academic performance, and poor relationship with peers go on into adulthood and intimate relationships. So now let's look at behaviors from a trauma-informed perspective to have a deeper understanding of where those behaviors are coming from. The brain is developed through a sequential and hierarchical progression. The brainstem is one of the first parts of the brain to develop. That is, for instance, where the heart rate is controlled. And as you probably know, heart rate, you hear that very early in gestation, and it is controlled by the brainstem. When we move up, we have development of the limbic system also occurring before birth. And that is where we have a lot of our sensory memories, and that is where we also process factual information. More details on that here in a couple of slides. And then the last part of the brain to fully develop is the neocortex, or the prefrontal cortex, which is the thoughtful part of the brain. So next slide. So let's look at the limbic system. The limbic system is, consists of several organelles. First, the amygdala. The amygdala is the fight or flight part of the limbic system. So this is where sensory information comes in. We don't think about it. It happens in split-second time that our bodies make an adjustment and a decision, critical decision in some instances, to either fight or to flee a dangerous situation. This is developed very early on and is essential for human development, especially human development over many years prior to civilization. Also in the limbic system is the hippocampus, and the hippocampus is the area where we receive and lay down and retrieve factual information. So this is very important for learning. The hippocampus is where we can remember the information, such as the capital of California, and be able to respond to an exam question when we're asked that factual information. The hippocampus is very involved in that process. Interestingly, it's very close to the amygdala, and there are times, I'm sure we have all experienced those moments, when our emotional reaction to a particular situation adversely affects our ability to retrieve factual information from the hippocampus. Now, the prefrontal cortex is, again, in that neocortex, the last part of the brain to fully develop. That is the thoughtful part of the brain. That is where we make judgments. That is where we remember the rules. That is where we achieve our goals. And that is also where human behavior can be controlled in a thoughtful way. Self-regulation actually comes from our exercising our thoughtful part of the brain, the prefrontal cortex, so that when we feel an overwhelming sensation triggered by sensory input that we're not fully conscious of, and our amygdala is starting to react, we can exercise our prefrontal cortex, and the prefrontal cortex, through neural pathways, will communicate with the amygdala and cool down the amygdala so that we are not being fully impulsive or reactionary, but actually being thoughtful about our behavior. Sometimes the amygdala is referred to the hot circuit because of its highly emotional and sensory responses and trigger fast responses. And the neocortex, or the prefrontal cortex, is described as the cool circuit. And it does, in fact, really cool down the reactionary sensory reactions that we have in our behavior. Now, interestingly, stress and cortisol, stress hormone, has the effect of blocking the neural pathways from the prefrontal cortex to the amygdala, so that under stress we do not take time to think about our behaviors. We oftentimes react spontaneously. And again, this goes back to that basic survival mechanism that our brains have been hardwired to endure. And so we are less thoughtful about our behavior under stress. And even as adults, we experience that under stress. My behavior is less mature and more reactionary than when I am not under so much stress and able to be more thoughtful and mature in my responses and behavior. Also, as part of stress is that adrenaline surge that we experience, and the adrenaline actually promotes the pathway to the amygdala. So we have not only a blocking with the cortisol stress hormone of our prefrontal cortex informing our behavior and inhibiting the amygdala reactionary response, but we also have under stress adrenaline that is promoting our reactionary response to the environment. And in fact, studies have shown that under chronic stress, those people under chronic stress actually have a larger amygdala and smaller prefrontal cortex because they have used their amygdala more than average and have not had the opportunity to use their prefrontal cortex as much. Now, Graham's study looked at babies and what is going on in the baby's brain during stressful situations. This study involved surveying mothers using a standardized questionnaire to assess the level of domestic conflict, not physical, this was verbal, conflict in the home. And then the mothers brought in their babies, and the babies were put in a functional MRI with a headset on, and through the headset, while the babies were sleeping, they were hearing unintelligible, angry voices while they were sleeping. So they were not hearing words, they were only hearing the tone of angry voices during their sleep. And what they found looking at brain activity while they were sleeping, hearing this sound, was that among those babies whose mothers reported higher verbal conflict in the home, they had more robust firing of the parts of their brain that controls emotional processing, or actually I should say activates more emotional response than those babies whose mothers reported less verbal conflict in the home. In fact, there was a correlation, so there was a dose-dependent response, a linear relationship from very low response when there is not a conflict in the home to ever-increasing response to a high response of brain activity in the babies who were coming from a home where there was high conflict. And also there have been studies that show that this development, this brain development, influenced by the degree of conflict and stress in the environment begins during pregnancy as well. So I begin to question what is temperament, and temperament for me is what through behavior is identified as in the environment in which the child's brain was developing prior to birth. And we know that there are protections for protecting the developing fetus when the mother's cortisol stress hormones become elevated, and the placenta really does serve to protect the fetus from those elevated cortisol levels with an enzyme in the placenta that actually breaks down the cortisol. However, over time in chronic stress, that becomes that enzymes become overwhelmed, and that cortisol can pass through the placenta to the developing fetus. And so a baby can be exposed to elevated cortisol at critical times and adversely affects brain development. The results of this, some of the results include that there will be actually fetal growth retardation, and that's a medical term for that is in uterine growth restriction, so that those babies actually can stop growing and are born at a smaller size. Also, those babies, research have shown, have more reactivity. We were talking about the baby earlier, the 6-month-old, who has more reactivity to angry voices. It's more reactivity to even just novel situations or stressful situations compared to children who didn't have that exposure before birth. It also adversely impacts the immune system and the ability to lay down memories, thinking about that hippocampus again, and our behaviors, thinking about the prefrontal cortex and the amygdala. Those people will go on to be at risk for developing diabetes and will have an increased insulin response to a given glucose load compared to those who have not had that exposure, and will go on to have cardiovascular disease. So you just had a quick course on field programming and epigenetics. There's a lot more information in that area, very intriguing area of research right now. But we'll move on now to mirror neurons, because understanding behavior from a trauma-informed perspective also calls for us to understand how we as human beings have mirror neurons. And these mirror neurons that we have are neurons that are activated not only when we're doing something, but when we're watching someone else do that. And this is actually the foundation for the development of empathy. So through our mirror neurons, we feel others' expressed emotions. So when we are working with a child and that child becomes very upset, or we are working with a parent and that parent becomes very upset, we are feeling their emotion through our mirror neurons, and that is a very important characteristic of human beings that we all experience. But because we are the mature adult, we typically have the capacity to use our prefrontal cortex to cool down that response that we have that's generated by our amygdala and by our mirror neurons, in order that while we're feeling that emotion, we can respond more thoughtfully in those situations. But what happens when the child's behavior triggers our limbic system beyond our ability to cool it down? So what happens when we get triggered to the point where our prefrontal cortex does not help us cool that down? Well, one of the first things that happens is that we begin to get upset and feel stressed, and children, through their mirror neurons, experience our stress, and that becomes even a stronger sense of insecurity and feeling vulnerable for the child. And a child's natural reaction is to increase their communication to us that they're feeling insecure, in the hopes that they will have an emotionally available person available to them to help them co-regulate. But when we become triggered and overwhelmed, we will oftentimes retreat, because we need to regain our own regulation in order to regulate the child. So now that is where I'd like to finish up with talking just a little bit about organizational trauma-informed approach, because it is through our work and in our workplace where we can pull all of this information together and work toward having a workplace and work environment that is considerate of the trauma that we have all experienced, the triggers that we all naturally have as human beings, and the ways by which we can be supportive of each other to be fully productive and engaged with young children in our work. So we are the community caregivers for children. We are the mature adults that can co-regulate and teach children and parents a way of self-regulation that allows all of us to be fully productive and engaged in society. At the same time, we are also coming to this work with our own set of adverse childhood experiences, our own ways that our brain has responded to the environment within which our brains grew, and a recognition of and a feeling and experience of those influences on the way that we interact with others, including children. So how can we be respectful of our own past, acknowledge the importance of taking care of each other and being able to work in an environment that is best conducive to doing the work that we all want to do, modeling for parents a way that we can be respectful of each other and considerate of each other's emotional experiences in human interactions, so that through that parallel process, parents can carry that knowledge home and into the families to support their children in their parenting as well. I'd like to finish up here with a couple of slides referencing a SAMHSA report that came out that talks about this, and the information I'll provide here is at a very introductory level. It comes from that document. I really encourage everyone to download that document and consider ways through that document that workplace can be become a more trauma-informed approach. First, there are a set of 4 assumptions, and they're referred to sometimes as the 4 R's. It's first of all realizing the extent of the trauma, and we've actually talked about that here today. It's pretty safe to assume that we have all experienced trauma in our lives, and realizing that is the first assumption toward developing an organizational trauma-informed approach. The second is recognizing the signs and symptoms of trauma. And we've even talked a little bit about that today too, when we're talking about how we have our triggers when we're working with young children, and beginning to recognize those signs and symptoms of trauma is another assumption and a way of implementing a trauma-informed approach in the workplace. The third is responding by integrating that knowledge that we have into the way that we operate in the workplace in every aspect of the work. And the fourth is resisting and recognizing that people do become re-traumatized, and resisting and improving on the ways that we operate in order that those re-traumatizations are minimized. And I actually add a 5th one because it's also really important that we also want to have opportunities and policies and procedures and practices that allow for repair of that re-traumatization, which can also lead to repair of traumatization that we had in prior years. So the 6 key principles of a trauma-informed approach are, first, feeling safety in the workplace. And this is both physical and psychological safety. That is fundamentally important in order that we can move forward in developing a trauma-informed approach in the workplace. feeling safe at. And the second is building trust in those relationships. So just as children learn through relationships and thrive in secure, trusting relationships, we as adults do that as well. And one of the best ways to build trusting relationships is to operate with transparency. So having a method, a mode of operation in the workplace where there is transparency about what is going on and why and how is very important in order to build trusting relationships in the workplace. And through those relationships, we have peer support. We have support for each other. We have support for our clients that we serve. And we continue to build on that trust that we have in order to build resilience through those relationships with our peers that we work with in the workplace and our clients. Through that peer support, we learn of each other's strengths and build on those strengths through collaborative work and mutual setting goals. And here we really begin to thrive in the workplace when we have this trauma-informed approach. Through this process, we can develop a sense of everyone has a voice, that there are choices that we can make, and we can feel empowerment through that process to be able to fully operate and do the work that we are all dedicated to doing in a more effective way. And finally, it's so important to recognize that there are historical traumas and cultural considerations and gender issues, and being very thoughtful about those and being very respectful of those further instills a sense of safety, trusting relationships, a fertile ground for collaboration, and a strong sense of empowerment, voice, and choice. So in summary, child rearing is a community responsibility. Those experiences that we have all had affect our brain architecture, and those adverse experiences are common and really can be normalized and worked with in a constructive way. Those healthy relationships are certainly very important in building resilience, and behavior is an expression of previous experiences hardwired in our brains. And those adverse experiences can be repaired in healthy relationships, and a trauma-informed approach to our work and in the workplace can support everyone's efforts to promote healing from past trauma and build community well-being. So I'd like to ask you to please go back to the notes that you jotted down at the beginning of this presentation and thinking about your triggers, and think about what you have learned through today's webinar that helps you understand better what your triggers are and how you respond and to those triggers in your work and in your life, and as a way to help better understand yourself, which translates into understanding others. And when you have a chance, identify for yourself one trusted person with whom you can share your new insight, and set a time for having a conversation about what you have learned today. So thank you very much for your time this morning and for allowing me to share this important information with you. I hope that you have found it useful. We do have a few minutes if there are any questions, and I'd be more than glad to respond to those. So I will hand it back to Carrie.
Great, thank you, Sherry. First, I'd like to acknowledge really quickly that I realized some folks had some difficulty with the audio in the beginning, and I'm sorry that it wasn't clear that you needed to call in. So I'm glad everyone figured that out. Thank you for your patience with that. Also, Sherry had asked if there were folks from other states on the call, and we have Iowa, Alaska, and Wisconsin. So thank you all for joining us.
Yes, thank you. Welcome, and thank you very much.
Great. And I wanted to, we did have one question that came through. Someone asked, what does CAN stand for, C-A-N, that came up in the presentation, Sherry?
Thank you so much for that question, and my apologies for using an acronym. CAN, C-A-N, stands for Child Abuse and Neglect.
Great, thank you, Sherry, and we'll include that here. All right, we have a few more questions. Oh, of course, we also have Oregon listening. Sorry, we didn't acknowledge that. Yeah.
Welcome.
Welcome all of our Oregonians. We do have another question. So Valerie says, given our growing understanding of epigenetics and generational trauma, and given the U.S. history of displacement and trauma, where do we begin? And how do we get a clear idea of what healthy looks like?
Valerie, that's a fabulous question. Thank you for that question. It's a very insightful question. You're absolutely right. Transgenerational trauma is really very much a characteristic of American culture. Whether we are a Native American or an immigrant from another country, we have all, by the nature of the country that we live in, have experienced trauma, and those adverse effects can be transmitted from generation to generation. They're very deeply seated, and your question is so important. How do we even begin to deal with that? And I believe that today you have begun that process if you hadn't already. And in realizing that there is such a high prevalence of trauma, it's almost the norm in our culture, and that is the first big step. And then responding to that knowledge that we have and beginning to think about how we can be respectful of where everyone is coming from, how everyone is experiencing the world differently from ourselves, and how we can embrace that differentness in a respectful way and hold each other through this life journey that we are all on together, in order that we can be supportive of each other, work from a strength-based perspective with each other, and together go through a process of healing and repair and reduced re-traumatization wherever possible.
Thank you, Sherry. We had a few other questions about the training being recorded, and it is being recorded, and we will make it available on our website. Sorry for those that missed the first few minutes of audio. So we will make sure to email out to all who are registered once it is posted on our website. Someone also asked if you need to check in to the training. I can see everyone who is logged in here, and if you're logged in and registered, I'll make sure to get everyone's certificates if they're interested. If you are watching it in a room full of other folks, just have someone email me the names of everyone in the room, and I'll make sure and get you your certificates. Ann Erickson asks about resources to develop self-regulation and resilience. Sherry.
Oh, Ann, that's a great question. There are resources for developing self-regulation. There are some strategies and some resources. Some strategies, as you may very well know, I know this wasn't your question specifically, but you know, self-care is very important when in our work, and that does build self-regulation. Trusting relationships. Again, we don't have to be a child to be able to experience co-regulation. I experienced co-regulation as we were starting this webinar with Carrie today. So, you know, it's very helpful that to use those trusting relationships and supportive peers to co-regulate as a way of practicing our own self-regulation. In terms of resources, there is Mind in the Making. It's a curriculum that talks about executive function in general, and fundamental to executive function is the development of self-regulation. The strategy used by Mind in the Making is really a self-reflection in order that we can understand how children are developing self-regulation by understanding how we ourselves as adults are continuing to build on the self-regulation that we have. There are other parent education curricula also that talk about self-regulation and how to build that and nurture that.
Great, thank you, Sherry. All right, so we have a few more questions. So from Cindy, Cindy asks, Sherry, do you always have a reactionary response for life, or can you develop a better response over time and reduce your responses in the event that your stressful environment is reduced over time? In other words, will an adult always respond at a heightened level if they had a traumatized in utero or childhood experience?
Wow, what a powerful question that one is. That's a really interesting one to think about. I wish we were in the same room together so we could have a discussion rather than me responding. But I will do my best to respond. We know that brain development obviously begins during pregnancy, and brain architecture even during the pregnancy is influenced by environment. We also know that human brains have plasticity, and by that I mean human brains, the brain begins the brain architecture laying down those neural pathways, those neurons and the neural pathways, but they can also be influenced by changes in the environment and themselves change to that environment. So that's a fabulous opportunity early in life to affect the brain architecture of the young brain. We also know that while the prefrontal cortex is one of the last areas of the brain to develop, it's really in the mid-20s that it's most fully developed. However, my speculation is that we've continually pushed that age out, and we're seeing evidence that it is possible to further develop our executive functions, our prefrontal cortex, to influence how we react to the environment around us almost through the lifespan. You can't see me, but take my word that I hope that I am a living example of even in later life we can continue to work on our own executive functions, our own self-regulation, and influence which neural pathways we fire in any particular situation. So to answer your question, I think that we can do that throughout the lifespan, and in fact, as adults, we do work on our own regulation throughout life and recognize our triggers and develop, hopefully, healthful ways of dealing with the triggers that we inherently have throughout our day.
Wonderful. Thank you, Sherry, and thank you, Cindy, for that question. Nina asks if this training will be archived with audio so she can share it with her colleagues. She found it very helpful as a preschool teacher and works in an organization in stress and sees the effects of that in their relationships. Thank you, Nina. This will be archived with the audio as a video actually on our website, and we will notify everyone once that's available. We'd love for you to share it. We do have some more questions, and we do have time for them, so feel free to write in some, and we'll do our best to get to them. Rosanna asks, in an after-school K-5 program, you spend 3 or less hours with the children. So what is the best way to diffuse a situation that stems from home life trauma and manifests itself through behavior problems when you only have a few minutes to deal with it?
Wow, Rosanna, I so appreciate you bringing this right down to the practical level. It's very challenging when we as a caring adult and in our work want to nurture a child's development, and we have so little time in the day to be able to do that. So a couple of things come to mind. One is that a healthy relationship, even when it is only a few hours a day, does actually have an impact on that child's development. So although, Rosanna, you only have 3 hours a day with the child, and you're spreading those 3 hours out amongst multiple children, you really are making a difference, and that's important to keep in mind. I also appreciate that you wish to make a bigger difference, and so what I think about is we model how we wish for parents to interact with their children, and so that a parent can see through your work, Rosanna, that and the way that you interact with their child and the way that you talk about their child and delighting in their child being with you during the day, you are modeling for that parent a way that a parent can carry home with them and continue that process at home when the child is away from you. So you have a couple of ways. You should not underestimate the impact that you do have with that child, even though it's a few hours a day and not as long as you would like. You also have an impact because the nature, the manner in which you interact with that child can be observed by the parent, and the parent can learn from your expertise in interacting with the child to continue to carry your work forward and back into the home.
Great, thank you again for that question, Rosanna. Melissa asks, how do we support marginalized individuals who are not only recovering from previous trauma, but still undergoing perpetual lived trauma?
Wow. So, yeah, Melissa, I would love to hear more about your where that insight comes from. That's very insightful. We really need to think about, you know, that we are a caregiving community, that we are a community of caregivers, and that no one of us can do it all, and we really need to push this idea of community as a caregiver. And when we do that, we begin to think about, wow, I don't have to do it all. There needs to be other members of the community that are supportive of this work as well, and those include resources for families, housing and food, gainful employment. Those include opportunities to experience the out of doors. The out of doors is very regulating for all of us. Those include quality of life and opportunities and resources so that parents can be the parents that they want to be for their child. Opportunities for that child to experience quality child care, quality daycare, and a very high quality education and quality of life. So we really need to think about how we can support all families and people in our country that through that community of support so that everyone can repair the trauma that we've experienced and move forward and nurture the upcoming generation to be healthier mentally and physically.
Great, thank you. We had a few comments about Mind in the Making. Christy says that she read the book and recommends it to everyone. Her team read it, and Mandy says she went to a conference and heard about it and bought the book and is excited to get started on that. So we're glad people are using that resource. Nellie asks if you know, how does this relate to adults that on top of childhood trauma have PTSD or post-traumatic stress disorder?
So, Nellie, I'm so glad you brought that up, because we work with families who are challenged with mental health issues, and that's a very delicate situation. It's very important that we develop more resources and strategies for holding those families and supporting them to be able to parent their children. When we think about PTSD specifically, we can really lay that onto the information about the neuroscience that we've talked about today, and how someone with PTSD may be dealing with an amygdala that has been primed to be overreactive to a given situation, and more likely to react in lieu of rash and more thoughtful prefrontal cortex response. And so we really think about the fundamentals. So we think about the triggers. We try to reduce re-traumatization by having an environment that is welcoming and safe for that parent who's experiencing PTSD when they come into our setting, that they feel respected, that we help them through co-regulation, cool their hot circuit, and are able to then free up their cool circuit to be more operational in a situation. And then we go from there, building a trusting relationship with them, and a relationship where we help them feel empowered to be a part of the process of providing services for their children.
Wonderful, thank you. Cindy had a follow-up question to her question from earlier, in which she asked, do you always have a reactionary response, or can you develop a better response over time? So her follow-up question was, is it repaired in the brain, or do you just develop coping skills to deal with it, with that over-response?
Well, that's an interesting distinction. We develop first the ability to recognize when it's coming, and to begin to, if we use our prefrontal cortex, plan how we are going to respond. That's the first step in the process. The coping mechanisms over time become the process itself, and then every time that we fire a neural pathway, we are priming that neural pathway to fire more likely in the future. And so the coping mechanisms that we have are really our ways of prompting the firing of the more thoughtful pathway, rather than just having our bodies behave a reaction through reacting in the situation. So it's just like driving a car, I guess you would say, and that is, when you're first learning to drive a car, you have to be very thoughtful of every single step in the process, but then it becomes just part of how you do things, and that's true for our behaviors as well. So when we have a trigger and we want to be more thoughtful rather than reactionary, we first develop healthy coping mechanisms, and we keep practicing, and through practice we exercise that neural pathway that we wish to have fire, and then it becomes more likely to fire in the future, and we can become less intentional and more spontaneous in our reaction that is a more thoughtful and regulated response.
Thank you, Sherry and Cindy. So Mandy asks, as a child care provider and parenting educator, how do you go about establishing the language with other children who aren't dealing with trauma situations, but you want them to have empathy and understand that, or where that other children who they are interacting with is coming from? For parents, what are a few easy steps or skills to give them, or ideas to support them with trauma for their own children? So kind of two questions.
Okay, thank you, Maddie. So the first part of the question is how do we, if I could paraphrase, how do we teach empathy? Mm-hmm. And the second part is how do we help parents promote empathic behavior in their children? I hope I got that right. So first, it's another presentation I have, but it is impressive to me every time I present on empathy, because we can see empathy in extremely young children. Our brains are hardwired to be empathic. And it's everything from, those first few weeks after birth when a baby will actually imitate a facial expression that they see their caregiver have. That is the seed of empathy. There are videos, if you go to YouTube and just search on empathy and child, there are videos that show in research, in laboratory research, young children who are expressing, are demonstrating empathy in trying to help an adult. And when you think about it, for a child to survive, if we go way, way, way back now, for a child to survive, they had to be able to draw in a protective adult, and that's why babies are typically so cute. They draw us in, and we want to be protective of them. And they have to be hardwired to please adults, and that's that feeling that you get when a child emulates something that you're doing, and that's hardwired in the brain. So we want to help a child mature in the area of empathy, but we can also remember that the brain is hardwired to do that, and we're nurturing that process. And one of the best ways that we can do it is to be expressive of our own empathy in a particular situation. And children can pick up on that. And then that wondering question with a child, and sometimes collaborative problem solving can be a way of doing this systematically with a bit older child. To talk about what the experience was like, promoting perspective taking, which is another executive function, by helping that child think of the situation from another person's perspective helps them to become more empathic. And perspective taking is fundamental in play, and so it's really helping children, or not helping them, they do it pretty well without our help, but really encouraging children to engage in play, because through play they are taking on other roles and developing a sense of perspective taking. So those are ways to nurture the maturation of empathy that is seated and hardwired in human brains. And the way we can help parents in that process is helping parents understand what I've just said, and demonstrating it, being empathic with them. So through the parallel process, through our empathy that we demonstrate to the parent, helps them to be more empathic with their child, and helps their child develop empathy as well.
Thank you, Sherry. Melissa states, particularly I work with immigrant families or families of color who are constantly undergoing racialized antagonism and violence. Parents deal with constant microaggressions in their daily interactions. And so her question is, how do we sell the promise of healing when parents have no possible future without violence?
Wow, Melissa, you're doing some really powerful work. Your question really reflects that in a deep way. What comes to my mind is almost an ecological approach, and by that I mean there needs to be layers and layers and layers of change and proactive work to extinguish microaggressions, racism, all of the ways that society can traumatize a group of people and the individuals in that group in order that we can make the biggest impact. We can't just start in one place too. We have to start across that. And when I say ecological, I mean not only from self-care, but person to person, to the family, supporting the family, supporting the community, supporting society, and societal changes in order to really fully realize and addressing what you're pointing out, Melissa. So it's complex. One way to begin that process is to carve out, I don't know if you're familiar with the circle of security model, but just as that young child needs a safe haven to come back to refuel, we can carve out a safe haven for that parent, for that community to come to where they feel safe and secure and refuel and begin the repair process and building resilience. We can encourage parents and communities to use the resources that they have in the community, their cultural traditions, their faith. It can be framed in a way that is messaging to them that they're gaining resilience through those venues as well, and then sharing with each other that sense of safe haven and resiliency. That was not a very well articulated response. I'm so triggered by your question and feel tremendous empathy for the work that you're doing, Melissa, but I hope that it was helpful in some way.
Thank you, Sherry. We have a few folks that have just said thank you, and that this will help them practice with their staff and their parents. Nellie, who asked a question earlier, brings up a concern, and I wonder if you want to respond to that, Sherry. So she says, it's interesting that PTSD and/or trauma in children are not easily recognized, and more concerning that our society does not have more supports to help children, parents, and caregivers. So just a concern. Did you have anything you wanted to respond to that?
Nellie, you're so right. Children are so can be so resilient that they can present paradoxically different from adults when they're experiencing certain mental health conditions. And our paradigm for mental health often is very skewed toward adults, so that it's children who suffer mental health illness can go unrecognized. And then on top of that, even when it is recognized, there's such limited, such highly specialized professional resources available to families for those children. So the issues are very compounded. My heart goes out to you. We need to address that. I know that through infant mental health endorsement, which I tried to promote at the beginning of this presentation, is a very important way that we can do part of that work. We are just bringing in infant mental health endorsement into Oregon. It's already in Washington. It's already in Michigan, New Mexico, and other states. So that's one way that we can, as a workforce, with these highly specialized skills, can continue to build the resources that families need and children could benefit from when they are suffering PTSD or other mental health conditions.
All right, it looks like we have time for this one final question, as well as I'd like to acknowledge a few thank yous. Jenny states that it's always good to be reminded that there are reasons and backgrounds that can be affecting the behaviors of their children and adults. And Tiffany says that she agrees with Nellie, and how do we deal with families who we see children suffering with a family with mental health issues? I see children having no rights. How do we support a child or family when the family doesn't want help or denies that there is a need for help?
Wow. Yeah, Tiffany, you bring up some really important challenges that we face in the work that we do. Having parents on board is really key for the benefit of the child and their social emotional development. The ways, and it's not always an easy thing to achieve. What we can do, however, is again going back to those fundamentals of helping the parent feel empowered, helping them feel they have a choice and a voice in the process, and developing a trusting relationship with them, so that and using motivational interview techniques, asking permission to share some of our expertise with them when the timing is right, are ways that we can stay engaged with a parent even when the parent is not seeing what we're seeing and not yet ready to move forward on an action plan that we feel like would be a benefit to the child. And short of harming the child, which is another situation that we have to act upon, staying engaged with the parent, being available to the parent, and continuing to build that trust is really for the benefit of the child. And the child will observe that as well, and can learn from that process that we're modeling too.
Thank you, Sherry. Well, thank you all for these rich discussion questions. I'm happy that we had the time to continue this discussion with Sherry. Thank you to our participants in Oregon and Washington and Idaho and Alaska and Wisconsin and New Mexico and Michigan. We're so thankful you were all able to join in on this important conversation. I'd like to remind everyone that there are slide handouts that were emailed to you if you are registered, but also available for download through your go-to control panel, the handout slides as well as the SAMHSA information. And just remind you that you will be emailed your certificate, but feel free to reach out to me with questions if you have any issues with that. And lastly, I'd just like to thank Sherry so much for her wealth of knowledge and expertise in sharing this information with everyone today.
Well, I just thank you very much. I just have so much respect for all of us working in this field, and it's just tremendous work we're doing, and we should all feel empowered to move forward and do more.
Wonderful. Thank you, Sherry, and thanks everyone.
Thank you.